All right, so we're going to focus on lung cancer in Iowa today. This is a treat for me to not be talking about all the cancers, everything, everywhere, all at once. So focus on lung cancer today in Iowa. I'm probably not telling anyone anything they don't know here, but just wanted to sort of level set and talk about the epidemiology of lung cancer. It makes up 13% of all of our cancer cases and almost a quarter of all of our cancer deaths. We are ranked 13th in terms of our cancer incidence and lung cancer incidence, and unfortunately have one of the slowest declining rates in the US. I think there was a paper that came out not too long ago that basically indicated that we have made a state has made about the least progress of any state on lung cancer in the last couple decades. Fortunately, our mortality, we are only ranked 18th and declining, but I'll show a graph showing that we're still have a mortality rate that is above the national average. And we are ranked 8th for screening, which sounds better than it is because it still only means that about 10% of eligible cases are being screened in Iowa. So still lots of room for improvement. And here is the graph that I was referring to. You can see our very slow progress. We are the gold line here, and this is age-adjusted incidence of lung cancer. And you can see how much more slowly Iowa is declining than the rest of the US. Fortunately, our mortality declines sort of mirror the rest of the US, but we're at a higher rate. We're coming from a higher place here. I just want to talk a little bit about, given our large rural population, I wanted to compare urban versus rural, and they're very similar right now. In the most recent time period, you can see they're basically overlapping. But if you zoom out, you can see that our urban population in terms of rate of new cancer cases has made a lot more progress than our rural population, but they were coming from a higher place. Our rural population has made pretty modest decreases in incidence of lung cancer. And now, like I said, they overlap. Similar pattern with mortality. Just wanted to show some of our rankings compared to the other US states. Things that really stood out to me, if you are on state cancer profiles and you restrict the population to just the Black population in the US, Iowa ranks second. We have the second highest lung cancer incidence rate among our Black population. And if you restrict it to Black females, we actually have the highest lung cancer incidence rate among Black females. We rank 8th in Asian Pacific Islanders, 14th in our American Indian population, 17th in non-Hispanic white, and 31st in our Hispanic population. Males rank a little bit higher than females at 13th, but their rate is falling, whereas females, the rate in our females are stable and not declining. We rank a little bit higher, 12th in males under 50. Here, overall, we rank 17th in our under 50 population, 12th in males and 25th in females under 50. Among those age 50 plus, we rank 12th overall, and again, a little bit higher in males than females. If we look specifically at late stage lung cancer, which we are most certainly trying to avoid with things like lung cancer screening, we are 9th overall in the country. So just wanted to point out some of those sort of concerning rankings. In terms of the geography of lung cancer incidence in Iowa, we've seen this for quite some time where the purple, these are cancer reporting zones, by the way, that allow us to collapse our more sparsely populated counties to get more stable rates and allow us to break up our more populated counties to look at a more community level where we have large populations. And the darker the purple, the higher the incidence, the lighter the yellow, the lower the incidence. And we've seen this for quite some time, that those southern few tiers of counties in Iowa and the southeast kind of along the river tend to have some of the highest rates, along with some parts of central Iowa and up by Mason City. You'll also see the Waterloo area. This will come up a couple of times here, that the east side of Waterloo, where we have our highest Black population, highest percent of Black people in Iowa, has one of the highest lung cancer incidence rates in Iowa, whereas the west side, Waterloo and Cedar Falls, which have a much smaller proportion of Black people, and them have, one of the lower lung cancer incidence rates. And this is all one community. And as most of you know, Waterloo continues to be one of the most segregated cities in America, and we see some very concerning health disparities, including with lung cancer incidence. When we look to see if there's any different patterns between males and females, we still see the purple, the dark purple, and the higher incidence rates in southern and southeastern Iowa. A little bit different pattern here with females. We see a little bit more around the Cedar Rapids and Waterloo areas, and up in the north of Mason City. So slightly different patterns, but similar, some similarities also. And if we restrict just to our Black population, again, there's not a lot of places where we have sufficient numbers to get stable rates here, but we do in Waterloo, and you can see in each category, whether we look at males or females, and particularly females, we see a higher incidence of lung cancer compared to Black populations in other parts of the state. And when we look at lung cancer incidence by county, we've labeled the counties that fall in the top 10. Palo Alto currently has the highest lung cancer incidence rate in Iowa. I think Emmetsburg would be the largest city there. We also see clusters down here in southwest Iowa and also towards southeast Iowa, along with Jones County. We've also placed ACR lung cancer screening sites. This is not a comprehensive list of all the places where you can get lung cancer screening, but these are the ones that submit the required data and paperwork to the American College of Radiology. You'll note an example is the UIHC here in Johnson County does offer lung cancer screening, but are not sort of registered with this. So there could be more, but you can see that a lot of our lung cancer screening sites in Iowa are kind of clustered in the middle. There aren't a lot down here in southern Iowa where we see these high rates, and not a lot in northern Iowa either, as far as the ones we know about. Everybody's probably very familiar with risk factors for lung cancer, but I wanted to talk about a few in particular. You all know that smoking is the leading cause of lung cancer. About 80% of lung cancers, as well as about 80% of all lung cancer deaths, can be attributed to smoking. We know here in Iowa that radon is a particular concern, and it is the #1 cause of lung cancer among non-smokers. It is the second leading cause of lung cancer and responsible for about 21,000 lung cancer deaths every year in the US. And 2,900 of these deaths occur among people who have never smoked. Secondhand smoke is the third leading cause of lung cancer, responsible for an estimated 3,000 lung cancer deaths every year in the US. When we look at smoking patterns in Iowa, not surprisingly, they mirror a little bit the lung cancer incidence maps that I was showing you before. Iowa currently ranks 21st in smoking. We compared ourselves to Kentucky, which has the highest lung cancer incidence rate in the country, and Utah, which has the lowest lung cancer incidence rate in the country. So even though we look kind of average in that 21st ranking, we are only 2 percentage points behind Kentucky. We have about I think a 15%, and they have about a 17 and some percent smoking rate. So we're much closer to the state with the highest incidence of lung cancer than we are to the state with the lowest. Again, I'm sure most of you already know this, but just wanted to point out that in Iowa, close to 60% of radon test results were at or above the action recommended by the EPA of that 4 picocuries per liter. We have the third highest percent of tests above the EPA action level, just behind the Dakotas. And again, if radon is at or above 4 picocuries per liter, it's recommended to take corrective action. See, I see funny things coming in the chat that I probably should be able to look at after I'm done here. For smokers, this is one thing I really wanted to point out, is that for smokers, the risk of lung cancer is significant due to the synergistic effects of radon and smoking. So wanted to point out, just as an example, if 1,000 people were exposed to 4 picocuries per liter of radon, only 7 in 1,000 never smokers would likely be diagnosed with lung cancer versus 62 in 1,000 smokers. That's a very big difference in risk between smokers and non-smokers in terms of radon. So that's another thing to be aware of, is that interaction. And so brings us to the topic for today, lung cancer screening. We all know that for screening to be most effective in reducing the overall lung cancer mortality rate, more of the high-risk population should be screened. And currently, as we see here, current screening rates are very low among those at high risk. There's a lack of awareness of access, or low awareness and knowledge among patients and providers. Rates vary widely between states, and we all know that more can be done to increase screening rates, which is why we're here. And just to sort of hit that point home, if you can diagnose lung cancer screening early or at a localized state, you're talking about an almost 60% 5-year relative survival rate. That drops almost in half if it's at a regional stage, and only 9% of people with distant stage survive 5 years with lung cancer. Then when we look at, well, what is our stage distribution in Iowa, we're only catching just a little over a quarter at that early stage where they have the most best chance of survival and treatment to cure their disease. So lots of room for improvement because we see, we have half of people being diagnosed at that distant stage where only 9% can survive 5 years. So hopefully that kind of highlights and hits home the, let's see, how do I get back there? Hits home the critical importance of increasing lung cancer screening here in Iowa. There's a lot more that we can do to decrease our mortality. Outside of the topic of lung cancer screening, there's a lot more we can do to decrease our incidence of lung cancer, which would be is also critical to really reducing the cancer burden in Iowa. So I'm just really grateful to see so many of you here today, so many people passionate about this topic, and look forward to learning from our next speaker, Dr. Jamie Studts.
Thanks, Mary, and apologies for all the distracting heckles and jokes in the chat, but you had to know they were coming. So for those of you who don't know, I've known Mary for quite some time and admired her work for even longer, and so that was going to happen. So I am Jamie Studts. I live in Denver, Colorado, but I'm a loyal Iowan through and through, and I appreciate the opportunity to talk with you about some of the strategies that I believe are critically important to accelerating lung cancer screening, not just in Iowa, but across the country, and to apply some of the things that we've learned from my work at the University of Kentucky College of Medicine and the Markey Cancer Center there. But before I go even further, I want to see if I can give a shout out quick to my friends and family in Marshalltown, Iowa, where I spent my early years and continue to have family that lives in Marshalltown, and go Bobcats. Okay, so oftentimes we do tend to focus on the burden of lung cancer, and Mary has really done a nice job of clarifying it. But I also want to share the importance of things are improving, and we have a reason to be optimistic and hopeful. Smoking rates are declining to some of the lowest levels ever measured. Radon risk awareness is increasing, thanks to many of the great work of the folks at the University of Iowa. Lung cancer screening and early detection is accelerating. We see a drop in percentages of individuals who are actually participating, but that is because we've expanded the eligibility criteria to include more individuals who are eligible. Actually, the volume of screening is actually increasing in terms of the absolute numbers. Late stage lung cancer diagnosis is declining, incidence is declining, mortality is declining, survivorship is increasing. We're doing a better job of caring for individuals who are diagnosed with lung cancer in terms of symptom management and palliation. And lung cancer quality of life is increasing. I'm not saying that there's any time at all for victory laps. However, we have a reason to be optimistic and hopeful for this community and about this community, and embracing that optimism is part of the answer. It is part of what we must do in order to accelerate implementation of lung cancer screening and other domains within lung cancer. Oops. So just a few disclosures that I'm actually quite proud of. The opportunity to work with some of our industry colleagues at J&J and Genentech and AstraZeneca on changing the public dialogue around lung cancer, serving on the Scientific Leadership Council for GO2, and then some of my grant funding is listed there below. This is the reason we're here. It's a federal investment of nearly 250 million of your tax dollars that funded the National Lung Screening Trial. And if for any other reason other than returning value back to the taxpayer, we need to implement this. This shows that a 20% relative reduction in lung cancer mortality among individuals who participated in the low-dose CT arm of the trial, and a 7.7% reduction in all-cause mortality. There aren't any other studies out there that show any cancer all-cause mortality reductions associated with cancer screening. We have some of the best evidence to support lung cancer screening out of everything. And we want to infuse that optimism and that hope. More recently, the Nelson trial was published just a few years ago that helped us expand the eligibility criteria to individuals who are at slightly lower risk based on their PAC years and their age, but nonetheless demonstrated a benefit in terms of reduction in lung cancer specific mortality. So this brings me to this statement, and it's been backed up by I've been saying this for a few years, but some colleagues have recently backed this up with some actual analyses showing that lung cancer screening is currently the greatest missed opportunity to reduce lung cancer mortality. And I threw in a little flair here for Hawkeye, Cyclones, Bulldogs, and Panthers, not just throughout the U.S., but, lung cancer mortality and all cancer mortality. And that's because over the past few years, and Mary can shake her head if she agrees with this, the major declines in cancer mortality have come because of progress in lung cancer. There's not really any other domain that is moving as quickly and positively as lung cancer. And so if we can continue to accelerate this, and that's based on 4.5% implementation of lung cancer screening. If we got to 20 or 30 or 50 or anywhere near where we are at cervical, breast, or colorectal screening, we could be really doing so much better in terms of reducing lung cancer mortality. So this is filled with promise, this optimism, this hope, based on the evidence base, the strong evidence base, the policy support from Preventive Services Task Force and CMS and the VA and other sources that actually cover this first dollar coverage, meaning it's free. The issue is the implementation. It is a new modality. It is a new service. There are new people involved, and the process is a little bit more complicated. It's a little bit different. We have a targeted screening modality, not a population-based. So with a population-based strategy, all you have to do is check their age and to determine eligibility for the most part. We need to collect information about their smoking history, and we have to do it in a rigorous way that actually helps us stratify who is likely to benefit from lung cancer screening. And that comes down to the PAC years criterion. And Pack years has never been a healthcare defining variable. It was sort of nice to have, some people who really cared about tobacco cessation and things like that would include it in their electronic health records. But we've never really trained the people that collect this information to do it rigorously or to do it with a sense that it could impact the care that someone receives. And this is one of the things that you'll see some people say, we need to get rid of pack years because we can't measure it. Baloney. We can do a nice job of this if we train the people and that are collecting this information and also let them know that just how important it is to the healthcare that people receive. So defining pack years as a healthcare defining variable now elevates its significance, and it should elevate the training and support we provide to for the clinicians who collect that. So I want to reiterate what Dr. Charlton said about the guidelines. The current guidelines from USPSTF are here: 50 to 80, 20 pack years currently smoke or have quit within the past 15 years. And then the CMS guidelines, which are also coverage defining and coverage importance, are essentially the same criteria with a few less shorter years at the upper age limit. And that's critical because most of those individuals are covered by Medicare. So functionally, the eligibility criteria is 50 to 70, 77. But we often don't talk about the fact that we really need to consider if people are symptomatic, if someone is coughing up blood, they are not eligible for lung cancer screening. Those individuals need a diagnostic scan and a diagnostic pathway, and shouldn't be taken through a low dose CT. You need to skip straight to the full dose CT, and get that sorted. But what you really need, some people say, okay, the eligibility criteria is too complex. Here's what you need: 50, 20, 15. 50 years of age, 20 pack years, 15 years since quit. Those are the essential elements. So if you can get help your primary care clinicians and staff, all they have to do is remember 50, 20, 15 is a moniker that might be able to help. And of course, this color scheme is purposeful, a call out to the Hawkeyes. The other thing I want to say about guidelines and recommendations is that we often frame these, particularly in the lung cancer community, as our opposition. We think of them as the guidelines being restrictive, that the government or the programs aren't forced to pay unless people meet these eligibility criteria. But in reality, and here's a color scheme for the cyclones, that these eligibility criteria are participant and people protections. Lung cancer screening has real benefits and real harms. And we need to focus on the areas where we have a strong belief and strong evidence where the benefit to risk ratio favors benefit. And those individuals screening outside the eligibility criteria may choose to do so based on shared decision making and a thorough understanding of the benefits and harms, but it is not a recommended practice for the population of individuals who are eligible for lung cancer screening. So instead of seeing these guidelines as our enemies or our combatants here, we need to embrace these as participant protections that respect people in terms of their likelihood of benefiting from lung cancer screening. So it's not gone well. We've had evidence-based policy-supported lung cancer screening since 2015, essentially. And there's been a host of issues that we've faced with regard to implementing lung cancer screening. And so my apologies to Meredith Wilson for borrowing a little bit from his Music Man musical here, but we have troubles delivering this to the community. And what I want to transition here to is talking about some of the solutions that may help us do a better job of this. So I spent a great deal of my time, and why I was teasing Mary about Kentucky is because I spent a great deal of time in Kentucky as a faculty member at the University of Kentucky, University of Louisville for just about 20 years. But one of the things about Kentucky, one of the better things about Kentucky, perhaps, is that they build the Corvette. And in 2020, they put out this brand new Corvette, and it's a brilliant vehicle machine. I'm not a car person, but it looks beautiful and it seems to go fast, which dudes tend to like. And that's how I think about the low dose CT. It's a beautiful machine. It's ready. It's ready to rock and roll. We have a strong foundation of data and policy that fuel this machine. And that is ready. We have a primary care community. However, we've not supported very well. Yet they are the starting ignition strategy to get this going. And we need to support them in what we do. We have lung cancer screening programs that need to have a pit manager and a strategist and a navigator to help really get this ball rolling. And perhaps most importantly, we have candidates and participants who are really at the wheel of this thing, of this machine, and they have no clue what they're doing. They have no knowledge of what this machine can do for them. They're very experienced. And frankly, since we've not been doing lung cancer screening for very long, this is much more like a bumpy new road course as opposed to the Indy 500, where, you got a smooth sailing for 2.5 miles around that weird shaped oval that is predictable, planned, understood. Everybody knows, go fast, turn left. This is not that way. And so we have a lot to learn and figure out about implementing lung cancer screening. But what I'm going to emphasize, the most important part is the person in the driver's seat, and that is the participant or the candidate for lung cancer screening. And I want to emphasize the importance of putting that person at the center of our process. Of course, translation of new ideas takes time. But we can't be satisfied with that solution. But in another call out to my Iowa roots and Iowa folks, I think we've really suffered from the field of dreams fallacy here. We think that we've got this great data and incredible policy, and if we build it, they will come. Absolutely not, folks. I think the evidence is clear. You can build all you want, but they will not come unless you do a much better job of understanding the socio-ecological context in which we're trying to offer this. We have very low awareness among lung cancer screening, among communities, among organizations, healthcare systems, clinicians, let alone the screening eligible individuals who I will talk about in a little bit have a very complicated relationship with our healthcare system. We need to do things differently. We often use fear-based appeals and try to scare people into doing things. That's not going to work with this community. They're already scared of dying of lung cancer. There's not a human alive that doesn't understand the connection between smoking and lung cancer. We also use stigma-based appeals or even rational appeals. These are not productive strategies. These are what we've been using. These are not working. We need to change course and think about things differently. And that we need to train our communities of individuals who are offering lung cancer screening to this community to change their perspective, to infuse an understanding. Most of the people who offer lung cancer screening do not have a background in screening. For example, the surgeons who are dear colleagues in reducing lung cancer mortality are so enamored with screening. But how many times do you go to your surgeon and tell them, nah, I'm not going to do that? They're used to all patients doing everything that they say, everything that they recommend that do. That's not how screening works. Screening is a choice, and it's a process, and we need to support people in that process, and that's why shared decision making is so critically important in the mix of this. So one of the other ideas I like to push is to think about lung cancer screening from a socio-ecological context. And think about it, frankly, through this way. Our public and our society thinks that the community of individuals who are eligible for lung cancer screening are undeserving, because it's a self-inflicted problem and they should just quit smoking. Policy organizations, we have favorable policies, but there are still significant apprehensiveness about using them. Advocates are full speed ahead in saying, why is this not happening? Healthcare system, mixed. Is this a revenue stream? Are we even aware of it? We've done some work in Colorado showing that many CEOs at rural hospitals aren't even aware that lung cancer screening exists. And so how can you have a program if you don't even know it exists? lung cancer screening programs are kind of full speed ahead, but they're not always confident in what they're doing, or maybe they're overconfident in what they're doing and not spending enough time learning about their community. Primary care clinicians, we've put way too much of the burden of launching lung cancer screening on busy, complicated primary care clinicians. We are unfortunately a needle in a haystack of primary care, of all the responsibilities, and yet we ask them to be the primary sources of a lot of care around lung cancer screening, and there's a very little value economically to sustaining practices by infusing lung cancer screening into primary care. Our family and friends or social networks are largely unaware, and certainly candidates for screening are largely unaware, somewhat skeptical, apprehensive, and experience self-blame. And in one of the most heart-wrenching things, some of individuals who are eligible feel like they don't deserve it because they should have quit smoking a long time ago. And that's really personally heart-wrenching for me. So I want to emphasize the importance of getting the people part right. When we analyze our quality data, we're getting the technical parts largely right. Sure, we could do a little bit better here and there, but we have to think of the people part from the community. How do we communicate with the community? How do we support our lung cancer screening programs and have high quality navigation? And then continue to put the candidates and participants in screening programs at the center of the process and build it around them, not making them fit into the model of care that we want them to fit into, to make it easy on us, on our navigation, on our healthcare systems. But who is this community? And if we put them at the center of the process, the first step is understanding who they are. First of all, we have to recognize that they're stigmatized. Smoking in the United States and across the world in most areas is stigmatized. This community is isolated. They're often due to have outdated understanding of lung cancer, so they have a fatalistic or nihilistic attitude towards screening. They're lower resource individuals, so they have to be skeptical about things. And we don't have a trustworthy relationship with this community, so when we offer something to them, it's like, what are they trying to get from me? Kind of a situation. They're also disengaged. We don't value them in our healthcare system in the same way we do other individuals. And so they typically don't play an active role or don't have great relationships with primary care. And they're also something that Mary pointed out is they're dispersed. This is a disproportionate burden in rural communities and low resource and low access to care communities. And so while we don't want to adopt stereotypes to reach, to reach this community, but to do it, we have to be person-centered. We must understand the opportunities and challenges of the community that we're specifically trying to serve. And we have to use that framework and perhaps infuse the social drivers of health understanding in order to reach this community and support them through the cascade. And I want to highlight the importance of trust. But I actually don't. I want to focus on, we hear a lot about trust, mistrust, and distrust. We can't worry about any of that. We have to be trustworthy. We have to act in certain ways and communicate in certain ways that build engagement and support. And being trustworthy is what leads to trust. You can't just manufacture trust. It comes through behavior and actions and communications and things, and how we communicate with the community, whether it's the public, the referring clinicians, or the individual candidates who are eligible, matters. And it matters a lot, particularly at this time of implementing lung cancer screening, where we're just little babies at doing this. Our mammography colleagues are experienced senior professionals at doing this. In the same way with our the folks that do colorectal and cervical. We are neophytes still trying to figure out how to do this and work with the unique community that we're trying to serve. And so ours is a little bit different. And we have to infuse that trustworthiness at the institutional, but also individual level. And with regard to the health communications, we really want to raise awareness in a non-stigmatizing, non-pathologizing, non-blaming kind of way, sharing information, helping people become aware and engage them in making informed choices about their health care. We don't want to be persuasive, and this is really hard for cancer prevention control folks because we think they should be doing this. The recommendations say they should be doing this, but persuasion doesn't work without trust. We don't have trust. We've systematically demeaned this community by telling them they were not very smart for continuing to smoke or smoking at all. We don't have that foundation of trust in a lot of situation on a public health level. And so if we kick into persuasion mode, people recoil from that. Just think about somebody who votes differently from you. If you don't trust that person, is there any value in trying to persuade them? No. It just doesn't work like that. And so we have going back to the idea of wanting to be trustworthy in our messages, not trying to frame it like it's the greatest thing since sliced bread, nor denying some of the potential harms. We want to trust people with information, and hopefully they see us as being trustworthy. But there's great news. We know where these communities are. If there's one thing that we know public health wise about our society is who smokes and what group smokes more. Therefore, if we know that, we know where the lung cancer eligible people are. And those are in rural communities, veterans communities, our African American, our LGBTQI communities smoke at some of the highest rates of any population or any community that we have. Those with serious mental illnesses and are facing are receiving care are some of the highest smoking rates. People with different levels of abilities, American Indian populations, some segments of Hispanic, as well as some areas of urban. We know these. This is our roadmap. Burfus and NHIS and everything gives us a roadmap to our targeted outreach strategies. We can leave population-based strategies to hopefully when the CDC gets funded to do lung cancer screening to them. But while we're supporting our programs, it makes sense if we're working toward equity to identify those communities that are experiencing a disproportionate burden and invest there in our efforts. If you're going to spend time outside of your lung cancer screening program to build engagement, look at the roadmap that Burfus gives us in order to develop a trustworthy platform with these communities. I also want to highlight just a briefly notion. I don't have time to talk about the full story here, but if you combine a history of tobacco and smoking with aggressive tobacco control strategies since the Surgeon General's report in 1964, you get stigma, you get blame. If you have a cancer like lung cancer that has decades of being the highest, having the highest lethality, and you have decades of inattention and limited research until most recently, until the discoveries, you get a society that is nihilistic and fatalistic about the diagnosis. Let me ask you, what in your life do you do and continue to do if you think, A, people are going to treat me poorly when I do it, stigma, and it's not going to work even if you did, nihilism. That is the way our community that we're trying to serve feels when we offer them lung cancer screening. What do you do? Nobody continues to do things that where people treat them badly and they don't think it's going to work. That's a recipe for failure. And until we put ourselves in their shoes and understand it from their perspective, and until we infuse things, oops, it didn't come up, until we infuse empathy and understanding and hope into our messages, we won't be able to really leverage that engagement or build those relationships in a trustworthy manner. Because the other thing that we don't talk nearly enough about, lung cancer screening doesn't work on a one-off basis. It's a process, and adherence is critically important. Things did not change with one scan, a lung cancer screening. Public health does not improve with one off or one lung cancer screening. It's the second and third and fourth scans where we detect the lung cancer earlier and really start to change individual and population health benefits. So with our Kentucky Leads Collaborative, we developed the health communication and marketing best practices. We need to be very careful, we believe, in conveying accurate information about lung cancer screening, and it is harder than you think. People twist the statistics and we mismessage sometimes about the value of lung cancer screening. That our call to action is not get screened. And this is where I differ with some of my wonderful American Cancer Society colleagues that have messages around get screened. No, the message needs to be talk with a healthcare clinician, have a discussion, learn about this, build engagement, understand why it's important, and seek an unbiased presentation of LCS benefits, harms, and unknowns. If we're only out there sharing the benefits, that's not a trustworthy message. A trustworthy message acknowledges that it's not perfect. And so we don't play into people's skepticism about us when we share all the information with them. And we definitely want to avoid images and imagery that stigmatize or induce fear because these people already have that stigma. They already have that fear. I took this slide out, but if you go back to your Psych 100 Yerkes-Dodson law, there's an optimal level of arousal for every behavior. And if someone is already too anxious, making them more anxious about it does not improve their behavior. It actually causes them to falter and to underperform. We need to right size our messages. And right now, our messages need empathy and compassion and hope much more than they need fear and stigma. And we can start with that with the International Association of the Study of Lung Cancer language guide, which emphasizes person-first language around smoking and eliminating blame language to improve end stigma and improve equity. We also have a new tool that we've used to call the lung cancer stigma biopsy, but now we call it the lung cancer stigma communications assessment toolkit that helps us look at our materials, at the language we use, the imagery that we use, and the context in which we use that in order to refine our messages to help build engagement with the community, not necessarily to persuade or to cajole them into doing things that we think that they should be doing. And that work has been supported by the American Cancer Society, and I should have put the web link to those resources, but I'll try to make it available later. The two principles that have really helped us most in Kentucky get to where we are with lung cancer screening are emphasizing person-centeredness and community engaged. It's not been helping the radiology techs calibrate the radiation dose. They're getting that right. We're getting the people part wrong. And that's where we need to spend most of our time, energy, and effort. And I use this example a lot, and some of you may have heard it already, but what percentage of adults, if you were to go out in the street in Des Moines or in Iowa City and ask the next 100 adults, show them this picture and say, what is this? And what is a mammogram and who is eligible? Everyone's going to be able to tell you, even though 50% will be men and they will have never be eligible for a mammogram. Screening mammogram anyway. But then if you show them what this is and ask them what a low dose CT is and who is eligible for that, there's virtually no knowledge. But we need those things to be equal. We need for there to be social facilitation that lung cancer screening is just as acceptable as any other cancer screening modality, and it's an opportunity for those individuals who just happen to be eligible. One of the things we did to extend that is to do the Kentucky equivalent of the full Grassley, not quite the full Grassley because we only did development districts and not counties, but we had these back in 2013. We went and had conversations, community level conversations with clinician advocates and individuals, community representatives who were interested in reducing the cancer burden, had a bidirectional sharing. We had our registry folks like Mary come and talk about the burden, but then other folks talked about screening programs and other folks talked about their community opportunities and start sharing and normalizing that discussion. We also developed primary care clinician outreach, and with our Kentucky Leads Collaborative, we were able to reach over 1,400 primary care clinicians and almost 1,300 of their staff. These educational efforts normalize lung cancer screening within primary care, but they also create a supportive environment of establishing social norms around lung cancer screening among clinic staff. From that point, we also worked on working with lung cancer screening programs. We developed a quill system to really infuse that person-centeredness, that community engagement into the screening process by working with screening programs and defining quality and giving them feedback and access to resources, and then following them up and providing coaching and technical assistance to really do a better job of emulating what is possible, what was possible from the NLST and what we learned from that into community settings. Through that. We did this, we implement this in 10 sites across Kentucky. And when we did that, we showed that about, screening programs were receiving about 68% of the overall quality points in our system, showing areas for improvement. But throughout our system, we showed about a 13% increase in their quality scores over time, suggesting that the more higher quality that they implement, the more likely that they're going to help their individuals achieve better outcomes from lung cancer screening. And if you do all these packages of things, you can transform the climate in Iowa to one that's not really leveraging this platform quite as well as it could be to reduce the burden of lung cancer to a state like Kentucky. You would just not expect Kentucky to rally around this. But number two, and it pays off. And with data that from our registry that we've updated this a little bit, and I forgot to modify it, but the data is even better. You can see that from 2015 to 2019, the rate of late stage lung cancer diagnosis declined 2 times faster in Kentucky than in the US. And in our burdened Appalachian region that has the highest smoking rates, the greatest lung cancer mortality in the world, the rate of late stage lung cancer diagnosis had dropped 19%, which is 3 times faster than the US decline. So just to wrap up, that the NLST and Nelson create a really unique opportunity to reduce lung cancer mortality. There's tremendous promise and power in this platform and utility, but implementing it has become our challenge. And so far, I think the best we can say is maybe a D- in terms of our ability to really deliver this to the community. And we have an opportunity now to start to develop equitable and optimal strategies of communicating, of supporting this community, and of offering lung cancer screening. And those two pathways are person-centered principles and community engagement, and working toward normalizing this, removing stigma and fatalism from the equation, and really supporting the community of individuals who are eligible and helping them access and screening and support them through the process. And I will stop there and thank you for your humoring me and all my excitement about this lung cancer screening platform.
Well, thank you so much, Dr. Studts and Dr. Charlton, for joining us today. And thank you also to all of you who came to listen today. We do have some time for 1 or 2 quick questions, so you can either put them in the chat or you can unmute yourself, and we'll give you a couple of moments to pull those together. And in the meantime, one question that I'm curious about is, because I have a rural background, so how do we as a rural critical access hospital begin the process of getting more eligible patients in the door for specific service? And as well as, and how do we work with community partners to address the gaps and barriers in access to lung cancer screening services? Welcome for your ideas, Dr. Studts or Dr. Charlton.
Jamie, I nominate you to start.
Okay, I'm happy to do that. I'm going to say one thing that I strongly recommend and another thing I caution strongly against. The first thing is supporting our critical access hospitals in developing quality lung cancer screening programs. This is something that a critical access hospital can do. You have to have a CT scanner, and at this point, I'm making up a number, but 99% of all CT scanners can do a low-dose CT scan to the quality and parameters that are needed. There are still apparently some out there that cannot do this appropriately, and then that would not be appropriate for that institution to have a CT, a low-dose CT. The but we have to support them. And that's why the quality system and building the resources and encouraging them and talking with CEOs and helping them develop. Across the country, we have primary care clinicians who are leading screening programs. We have surgeons, we have radiologists, we have pulmonologists, we have, lots of different disciplines that can run this. And we really want to, infuse and make that available and trying to help more places. We did an analysis in Colorado where we mapped lung cancer burden, but we also mapped every CT scanner in our state against, similar to what Mary did with sites that actually have screening programs. And if we functionally expanded lung cancer screening to every CT scanner in the state, there was like 30 square miles of Colorado that would not be covered within 30 miles of a screening program. So it can be done. But the important thing about this is a revenue stream that is for screening programs. The vast majority of rural hospitals, the CT scanners most of the time sit empty, underutilized, but they have to be paid for. The maintenance programs have to be paid for. So if you're adding resources around that, it becomes revenue. Significant revenue for a screening program that is, most importantly, the right thing to do for the community. It's evidence-based. It's policy supported. So it's not revenue for revenue's sake. It's actually health supporting revenue that supports the health of our critical access hospitals in rural areas, as well as the population health benefit of it. Now, there have been lots of people who have promoted the idea of a mobile low-dose CT, and I strongly caution against that because that is a very technology-focused solution. I've already tried to compel you to say this is a people problem that has to be addressed with a people strategies. Those scanners have a $3 million purchase and budget that required an outlay to start one of those mobile low-dose CT programs. And what do? You send them directly into communities that are served by critical access hospitals. You're undermining the revenue that the local community could be reserving, could be securing, supporting their own community. And mobile low-dose CTs create a problem for adherence. If you're only in that community 3 times a year, and what if the person can't get off work those two days that you're in that community? That means they skip their scan that year. That is a recipe for bad outcomes. It's a very expensive solution. It's a fancy solution that many people that want you to spend a lot of money to buy those devices to do, and you can put your marketing. One of the things that I'm very suspicious of mobile low-dose CTs because the payments often come out of the marketing budget of hospitals and not necessarily the equipment budgets. What does that tell you? What the relative value of the and focus of the program if they're coming out of marketing budgets. So I encourage everyone to support rural hospitals and help them, partner with them, train them to do lung cancer screening so they can serve their community, support the economic viability of their rural hospital, and achieve everything without a huge outlay of funds.
I agree with everything Jamie just said. And I am going to put something in the chat. It's a few years old now, but to his point, like in Iowa, I think we're really great about networking and partnering with each other. And, built ICANN is sort of an example of a network of rural hospitals across the state. And Lori Pedig from St. Anthony's, which is now a critical access hospital, gave a presentation about, basically lung cancer screening. You can do it, like how they started a program. And I'm going to put a link to that in the chat right now. I think it's still available online if you want to see. And she's somebody who would love to talk to anybody about how they did it. Same with, I'm sure, Brenda at Mahaska. It sounds like they're doing it now. Our hospitals have found a way, and they're really good at talking with each other and helping each other. So I think that together we can provide the support and resources that it would take for our hospitals to offer this and make sure that I bet we can one-up Colorado. have even less than a 30 square mile. Since everything is 30 miles apart in Iowa, we should be able to get smaller than that in terms of having coverage for everybody. So I agree with that.
Yeah,
And
thank
so
you.
since it's Iowa, Mary, I wouldn't mind you beating us on that. We do have a few other geographic barriers to deal with than you guys.
Mountains. We don't have to worry about that here.
Mhm.
I think we have time for one more quick question. And this may or may not be a short answer, I'm not sure, but if a patient meets lung cancer screening criteria, what are you seeing for insurance coverage? So do a majority of lung cancer screening patients have to meet their deductible first?
So the answer to that should be no. This is a first dollar service as part of any policies that are enforceable under the Affordable Care Act or for the centers or for Medicare. You'll have to excuse me. I don't know Medicaid policy in Iowa. If the decisions to cover lung cancer screening through Medicaid are state by state and vary widely. Although I'm going to venture a guess that Iowa does cover it. Most states do. I think we're up to around 70% of states that that their Medicaid plans cover lung cancer screening, but I don't know the answer to that. The only folks that would require costs are completely uninsured, or the folks that are covered by policies that were permitted by our previous federal administration. And I'm going to stop talking about that now for fear of saying something that would be inappropriate.
All right. Mary, do you have anything to add? No? Okay.
No.
Well, we do have one more quick poll for you all before we wrap up today's meeting. So I think Bree is going to share that with you. So if you can fill that out, that would be very helpful for us. And for those of you that will be joining us at the in-person workshop on November 18th, first of all, it's not too late to sign up. So if you're here today and weren't planning on coming on the 18th, we would love to welcome you. So you can please get registered for that. One thing that it will be good for you to have that day is baseline data for your center if you have it. So including like the number of screenings that you've conducted and the number of eligible patients you might have for a lung cancer screening. I'm going to, or I'll have Bree put the link in the chat for registration. We will be sure to include any and all resources mentioned today in a follow-up email, so keep your eyes open for that. And thank you so much again for joining us. We look forward to seeing some of you all in person in the workshop in Ankeny on the 18th, and we hope to see everyone at future consortium events. So thank you again to Dr. Charlton and Dr. Studts for your time today, and thank you all for your attendance today, and have a great afternoon, and we hope to see you again soon.